Hi, this is Will McMurray, and this presentation covers the Family Nurse Practitioner Foundations of Practice. The nurse practitioner role is an advanced practice nurse. They're trained at the master's or doctorate level. The NP is able to assess, diagnose, and treat illnesses within the limits set by their state boards of nursing. Their capabilities include performing, ordering, and interpreting diagnostic tests and prescribing medications. They're not meant to be a physician substitute, but are to work in collaboration with physicians and to provide quality, affordable care. The NP role began with its roots in the late 1890s, although it was not referred to the nurse practitioner title until many years later. In the 1890s, the nurses Lillian Wald and Mary Brewster were providing care to European immigrants at the Henry Street Settlement in Manhattan. Wald and Brewster provided meals, medicines, and medical care, and they also referred to local physicians as needed. So they really had the nurse practitioner role, in a sense, in the late 1890s. By the 1900s, there were 12 nurses employed at the Henry Street Settlement, and they made over 26,000 home visits. The Frontier Nursing Service was established by Mary Breckinridge in rural Kentucky, and the service was established to show how nursing midwives could improve one of the nation's highest rates of infant mortality. This was in the early 1900s. Nurses traveled alone on horseback to reach the rural population, and no physician oversight was present. Later, in the 1960s, the nurse practitioner role was established formally, and it was done so to bridge the gap to affordable care for pediatrics and families. It was initially established in rural Colorado by a professor of nursing, Loretta Ford, and a pediatrician named Henry Silver. The family nurse practitioner role is also an advanced practice nurse. They're trained now at the master's or doctorate level. They're able to assess, diagnose, and treat illnesses set with the limits of their state boards of nursing. The family nurse practitioner treats patients ranging from pediatrics to geriatrics, and they provide quality care to the full family. They work either autonomously or in collaboration with a family practice physician. The FNP role was really seen very well with the Henry Street Settlement that we mentioned earlier. And then the Frontier Nursing Service, these midwives in the early 1900s often provided emergency care and family care when physicians were unable or unavailable to reach the patients due to how rural the area really was. So at that point, the nurse midwives were often providing what would have been later termed the family practice role. And then in the 1960s, the nurse practitioner role was formally established. And the NP role has developed several specialties, including the FNP, who treats patients ranging the full width of the family and working either autonomously or in collaboration with a physician. The FNP promotes and preserves healthy communities, with over 49% of NPs in the FNP role. Is by far the largest role of nurse practitioner. Compared to other providers, the FNP is more likely to practice in underserved and rural populations, other providers being physicians or physician assistants. There's extensive evidence that nurse practitioners offer equal or better care than other providers. And by offering this quality care to the entire family, the FNP is able to address and treat health risks that affect the entire family before the risk becomes a chronic condition. So by educating the family and promoting health through all ages, the FNP improves and promotes community health. The scope of practice of the FNP is in assessing and diagnosing, managing and treating chronic and acute illnesses, in disease prevention and health promotion. It includes ordering, conducting, and interpreting diagnostic tests, prescribing medications and therapies, teaching and counseling of patients, practicing as either a health team with other providers and also autonomously, and in healthcare research. The scope is set by the State Board of Nursing in collaboration with the Medical Examiners Board. The standards of practice are that these advanced practice nurses will have an education of either master's or doctorate level at this time, although some are grandfathered in the past with lower levels of education. They serve ambulatory or acute care populations. That they follow the scientific process and national standards of care. That there's an emphasis on patient and family education and participation of the patient in their own care. The FNP will always be a patient advocate, and participation in quality assurance and continuing education and research are all standards mentioned by the American Association of Nurse Practitioners. State practice acts regulate the FNP practice. They exist to protect their citizens from harm. Every state has a Nurse Practice Act, and that act creates the boards of nursing. Regulations are decided by the boards of nursing. State practice acts cover education requirements, scope of practice, requirements for licensure, and disciplinary action, and have the full power of the law behind them. Reciprocal discipline between states allows a nursing board to discipline a nurse for unethical actions even outside of that state. This prevents a nurse from fleeing discipline by leaving that state and further protects the public. A current challenge towards role implementation is prescriptive privilege. Prescriptive privilege may enable or hinder the FNP. Authority varies from state to state. Many states limit prescriptive privilege of the NP and may require a physician for co-signature. The AANP advocates that prescriptive privilege should be uniform nationwide and without restriction. Regulation should solely be by the Board of Nursing rather than overseen by the Medical Examiner's Board. Ability of the NP to prescribe medications, treatment, supplies, and equipment without restriction is essential to the NP's ability to provide effective, quality, cost-saving care. The national certification for the FNP is a formal recognition of the knowledge, skills, and experience demonstrated by the individual who has completed an accredited NP program. National certification exams are either through the ANCC, the American Nurses Credentialing Center, or the AANP, the American Association of Nurse Practitioners. National certification must be accepted by the State Board of Nursing to obtain licensure, so certification does not guarantee licensure. FNP state licensure. Licensure of the FNP is a granting of the authority to practice, and the authority is granted by the State Board of Nursing. Regulations often decided by a collaborative team that are formed by the Medical Examiner's Board and Board of Nursing. The scope of practice depends on the individual state licensing body. There's no uniform national scope of practice. The National Council of State Boards of Nursing, the NCSB, is promoting the consensus model, and has been for years now. That'll be a nationwide standard for NP licensing and scope of practice. Licensure versus certification. Licensure is the authority granted to practice as a nurse practitioner. An example of this would be after meeting the requirements set by the Board of Nursing, like completion of an accredited NP program and passing a national certification exam. After that, the individual may apply for a state license. Certification is performed by one of the national NP certification exams, and that'll be through one of the groups mentioned earlier, either the American Nurses Credentialing Center, the ANCC, or the American Association of Nurse Practitioners, the AANP. An example of this will be after graduating from an accredited NP program, that the individual must take a certification exam through either of the credentialing bodies. The process to engaging in practice is graduation, followed by certification, and then by licensure. So after licensure is obtained, you'll have to be credentialed and privileged in a healthcare facility. Credentialing of the FNP is a process of assessing and confirming the license, certification, education, and experience of a healthcare practitioner. It's the responsibility of a healthcare facility before privileging the FNP to practice in that facility. And then privileging is the authority granted by the facility for the FNP to practice in the facility after the FNP has been successfully credentialed. Legislative versus regulatory processes are that legislative processes are brought into action by lawmakers. They're authored by lawmakers and have the effect of the binding force of the law. Compared to regulatory processes are brought about either or altered by an agency or board who's been granted authority through previous laws, like legislation. An example of this will be the boards of nursing have regulatory powers granted through legislation, like the state nursing acts. So the state nursing acts are legislation, and they grant regulatory powers, which are shown as the board of nursing. A current regulatory issue for the FNP is developing a national standard for scope of practice and licensure, and this regulatory issue depends on each state accepting the national standard for FNP practice. Currently, standards vary state to state, including standards for prescriptive authority and independent or dependent practice of the NP. The National Council of State Boards of Nursing is promoting the consensus model, the nationwide standard for NP licensing and scope of practice. So that concludes the presentation. Here are the references. Thanks.